Yeah? Okay. Okay, good morning, everyone. For those of you that don't know me, my name is Mike Ng. I'm one of the PGY4s at UBC. And I'm going to be talking about nephron-sparing treatments for renal tumors. Now, the topic came about when I went to Cleveland for electives and was able to see some laparoscopic partials and laparoscopic cryoablations, and that was a pretty good topic to talk about. Now, for the residents that are sitting in the crowd right now, there's a lot of questions about nephron-sparing treatments. You know, should we be doing partial nephrectomies for T1b tumors? What's an adequate margin for a partial nephrectomy? What are the intermediate results of laparoscopic partial nephrectomy? What's the most recent data on cryo and RFA? And did Spencer just take the last donut right now? Anyways, I just want to review the history of partial nephrectomies and review the four major treatments for small renal tumors. So really in the 19th century was the first experiences with nephrectomies and partial nephrectomies. And then later on in that century, there was further experimental feasibility studies taking a look at whether it or not it could be done. However, it lost favor because of a fear of complications. In the early part of the 20th century, it was reserved for polar, small, moderate tumors. However, it was contraindicated if the opposite kidney was healthy. And it wasn't really until 1950 when Vermeulen laid the foundation for modern nephron-sparing surgery. He was aware of the autopsy studies by Bell and Hale that demonstrated the low metastatic potential of small renal tumors. And he proposed essentially elective nephron-sparing surgery in that if the opposite kidney was normal, there were instances where nephron-sparing surgery would be indicated. The 1960s had significant improvement in nephron-sparing techniques, the use of segmental blood supply in the surgery as well as renal hypothermia. However, partial nephrectomy is still being done only in essential cases. It wasn't really until the mid-1970s when radical nephrectomies were questioned, even if there was a normal contralateral kidney, by these surgeons. And it wasn't until the 1980s when the era of elective nephron-sparing surgery was really begun. There was increased incidence and detection of small renal tumors on CT scanning. There was improvements in kidney reconstruction and renal hypothermia. However, it's hotly debated. It wasn't until the late 1990s when it became the standard of care with improved hemostasis techniques, the use of argon beam coagulator, and as well 10-year long-term data by Her and Fergani. And it's really been the late part of 1990 and this part of the decade where laparoscopic partial nephrectomies, cryoablation, and RFA were first introduced and being developed. And so when you break up the indications for nephron-sparing treatment, there's three areas: absolute, relative, and elective. Elective is basically when you have a normal contralateral kidney, and that's somewhat changing right now as to the size of the lesion. So let's talk a bit about open partial nephrectomies. We're all familiar with the different techniques that can be used for partials. However, they all follow the same basic principles: the approach, inspection of the kidney, isolating the vessels, settle protection, inadequate resection, and hemostasis enclosure. And I wanted to talk a bit about portions of the technique of open partials, and the first is warm ischemia. It's been long held from the studies by Ward on dogs in 1975 that warm ischemic time of 30 minutes is the maximum allowed, with complete recovery of renal function in 3 to 9 days. However, if you take a look at his experiments, warm ischemia time of up to 60 minutes often has a complete recovery of renal function in a matter of weeks. And actually, more recent animal studies looking at porcine solitary kidney model show that warm ischemia time to 90 minutes, although it had an initial decrease in GFR at 72 hours, had a normalization of GFR at 2 weeks, and in one study at 1 week. In fact, there's been two clinical studies taking a look at with a normal contralateral kidney, warm ischemia can be tolerated up to 55 minutes. We know that functional impairment is more if you clamp both the artery and vein, or if there's intermittent clamping versus continuous clamping, and manual compression of the kidney is worse off than clamping the kidney itself. Solitary kidneys and those kidneys with collateral blood supply have enhanced renal tolerance to warm ischemia. Yep. I couldn't really find out. Sorry? The hilum. Yeah. For renal hypothermia, the optimum temperature is 15 degrees Celsius. However, it's easier to maintain a temperature of 20 to 25 degrees. This can afford renal protection for 90 minutes to 3 hours. The most common way of doing this is renal surface hypothermia. However, perfusion hypothermia with intubation of the renal artery is possible and provides equal efficacy in maintaining a temperature. Taking a look at margins, with frozen section analysis, it's usually done grossly with or without microscopic inspection. And there's been some studies taking a look at whether or not this is in fact necessary. As well, the size of the margins has been traditionally 1 to 2 centimeters, but currently a standard is 5 millimeters and possibly even 2 millimeters. So this is a study done in Israel taking a look at 300 cases, and essentially they analyzed their frozen section analysis. They had 2 positive frozen sections intraoperatively, and this necessitated an immediate radical nephrectomy. On the final pathology, there was no residual tumor in the radical nephrectomy specimen. Taking a look at 4 cases where the final pathology came back with a positive surgical margin, however, the frozen section was negative. 3 of those 4 cases actually have had no recurrence with a follow-up between 26 months and 120 months. 1 case did, however, have a local recurrence, which required a radical nephrectomy. Taking a look at the size of the margin, this is a study done at Case Western University in Cleveland. There's 44 open partial nephrectomies with a mean follow-up of 4 years. There is no local recurrence at the resection site, and the median margin size was 2 millimeters. At the majority of the cases, the margin was less than 5 millimeters. Taking a look at hemostasis, suture closure of the vessels and collecting system is a standard. You can use argon beam coagulation to help as well as the use of thrombotic agents such as gel foam, Tisiol, Focio, and Surgicel. For complications, the mortality is between 1 and 2%. The most common complication is probably urine leak with 7% incidence. An incidence of dialysis or acute renal failure is between 5 to 6%. And the risk of bleeding requiring blood transfusions around 3%. Renal function following partial nephrectomy. This is a study from Mayo Clinic comparing radical nephrectomy versus partial nephrectomy. They're both matched for stage, grade, and tumor size. And they found that there's a greater incidence of progression to renal insufficiency in the radical nephrectomy group compared to partials. In more recent series, there's a greater than 90% disease-specific survival of open partials with a local recurrence rate of between 0 to 10%. Taking a look at elective nephron-sparing surgery where there's a normal contralateral kidney, again, similar results of 90 to 100% disease-specific survival with a local recurrence of 0 to 7%. Taking a look at long-term results, these are studies done at Cleveland Clinic and Memorial Sloan Kettering with a minimum 10-year follow-up. At the Cleveland Clinic, this is a study with a significant proportion requiring nephron-sparing surgery for imperative indications. When they stratified the data to tumors less than 4 centimeters, there was a 5-year survival of 98% cancer-specific. Similarly, at MSK, they had a 97% cancer-free survival. These are studies taking a look at comparing partial nephrectomy versus radical nephrectomy, and it's a retrospective series that were controlled for age, gender, tumor size, stage, and grade. And as you can see, taking a look at those that were treated with radical nephrectomy versus open partial, there is equivalent 5-year cancer-specific survival. The question of whether a tumor location has implication, essentially central tumors versus peripheral tumors, was answered by several studies by Hazef and Black. Now, central tumors have technical considerations in that it takes longer clamp time and there's a greater need for collecting system repair. However, it's not a prognostic indicator of outcome in that there's no difference in nadir renal function, local tumor recurrence, or 5-year cancer-specific survival. As you all know, the TNM staging has been modified to T1A and T1B with a 4-centimeter cutoff. This is a study at Cleveland Clinic taking a look at that 4-centimeter cutoff and basically showed that those tumors less than 4 centimeters had a greater 5-year cancer-specific survival compared to those tumors greater than 4 centimeters. As well, it had a lower recurrence rate. However, it wasn't truly a true comparison between T1A versus T1B because a third of the patients that were greater than 4 centimeters were actually greater than T1s. And they had a greater proportion of tumors that were of higher pathological stage, like T3A or T3B. As well, they didn't have a control group that was undergoing radical nephrectomy. So they didn't really demonstrate that a partial nephrectomy is even worse off than a radical nephrectomy for those patients with tumors between 4 and 7 centimeters. So this study took a look at exactly that question, whether or not radical nephrectomy or partial nephrectomy was better for those tumors between 4 and 7 centimeters. However, this study was fraught with a lot of problems because it was a heterogeneous population with differences in mean tumor size as well as pathological stage and histological subtype. A better study was this multi-institutional international study with 7 centers in Europe and at UCLA, a large N, and all of them had pathological T1 disease with a mean follow-up of 5 years. And within all the groups, there was no difference in Furman grading or ECOG status. So taking a look at the top left, that's the Kaplan-Meier cancer-specific survival curve for T1As, and it shows that there's really no difference between open partials versus radical nephrectomies. Similarly, T1B lesions, there's no difference between partials or radicals. So taking a look at univariate analysis, there is no difference in outcome when you take a look at the type of surgery that was performed. As well, they didn't find a difference in tumor size comparing T1A versus T1B. So taking a look at T1A lesions, again, there's no difference in cancer-specific survival between partials and radicals. And then for T1B lesions, there's no difference between the two groups. Taking a look at recurrence rates, those that underwent partial nephrectomies, there is no difference between T1A or T1B, no statistical significant difference. Taking a look at T1A lesions, again, no difference between partials or radicals. And T1B lesions, no difference between partials or radicals. And so these local recurrences can be from 3 mechanisms, either incomplete resection of the tumor, occult multifocal disease, or development of a new primary or metastatic focus. And these are a bunch of studies taking a look at nephrectomies or autopsies, looking at the incidence of multifocality. And they reported an average of 15%. However, it's really dependent on the stage of the tumor, the grade, and the histological subtype. And so when it's stratified for tumors less than 4 centimeters, it's probably about 5% multifocality. So in summary, for open partials, it provides equivalent oncological efficacy for tumors less than 4 centimeters with a 90 to 100% cancer-specific survival. Renal function is preserved, and the incidence of multifocal renal cells probably account for the majority of the local recurrences. There's a question of whether or not to expand the indications to T1B lesions. Taking a look at laparoscopic partial nephrectomies now. The approach can depend on level of expertise, but if you draw a line through the hilum of the kidney, those tumors that are located anteriorly can be approached transperineally, and those posteriorly can be approached retroperitoneally. Disadvantage of retroperitoneal is it's a smaller working space and somewhat more difficult to do intracorporeal tying because of that. Use of laparoscopic ultrasound is especially helpful in endophytic and central tumors. There's a lower positive margin rate from this abstract, the AUA in 2004. The question of whether or not to use laparoscopic ultrasound to detect multifocal tumor, well, in comparison to preoperative CT imaging, there's no real advantage for using laparoscopic ultrasound for this purpose. Again, if there's a warm ischemia time of greater than 30 minutes, it's recommended that hypothermia be used. However, it's quite cumbersome and difficult to institute these techniques. Gil described using an endocache bag. He's done this in about 13 patients. A group in Austria talked about cannulating the femoral artery and having iced renal Ringer's lactate running through the renal artery. Some groups advocate using a retrograde approach, inserting a ureteral access sheath and irrigating cold fluid through the kidney that way. There's a question of whether or not to clamp or clamp. The study was done in France. It basically showed that the unclamped group had a longer operative time as well as higher blood loss. The majority of the studies in laparoscopic partials are taking a look at hemostasis techniques. And one of the techniques discussed is tourniquets, which relies on regional hypoperfusion without the need for Hyler clamping. There's been cable ties, double loops, micromeshes that have been used in animal studies and some small human clinical trials. However, they're only really reserved for peripheral and polar tumors and truly unreliable for the kidneys in human studies. As well, argon beam coagulator could be used. However, you should vent the ports because of barrel pressure. And the use of tissue sealants have been shown to decrease hemorrhage and urine leak. A lot of studies looking at coagulative energy approaches. Animal studies taking a look at water jet dissectors, lasers. However, it's been shown that ultrasonic shears, bipolar, and microwave technologies may be suboptimal for partial nephrectomies. There's a recent study taking a look at radiofrequency coagulation, where they radiofrequently ablate the tumor and then proceed with a resection or partial nephrectomy. However, the standard remains suture closure reconstruction, especially in larger and central lesions. So to review the technique, it's a watertight closure of the collecting system followed by the vessels. Can apply flow seal to the renal bed, apply a Surgicel cigar, and then place sutures to bolster the cigar in place, either using Hemoloctite clips or Lapar ties to really decrease the amount of intracorporeal suturing, the tying you have to do. Taking a look at the Cleveland Clinic series and their complications in 200 patients. The incidence of renal insufficiency is 2%, urine leak 4.5%, and hemorrhage 10%. It should be noted that this series has a quarter of them are central lesions, and a significant proportion of them require pelvic calyceal repair. So it's not your typical laparoscopic series. And they did note that with the introduction of flow seal, their rate of hemorrhage decreased to 3%, and their rate of urine leak decreased as well. However, this could be from increasing surgeon experience as well. Cleveland Clinic also took a look at comparing central tumors versus peripheral tumors, and essentially they show that it could be done. However, there were higher incidents of early postoperative complications, especially hemorrhage and urine leak. And taking a look at the oncological results, as expected, it would be similar to open. Taking a look at the Cleveland Clinic series and Hopkins, the cancer-specific survival of 100% with follow-up of 3 to 3.5 years, and essentially no local recurrences. The two local recurrences at Hopkins, one was from recurrence from VHL, and the other was at a site remote to the resection site. Comparing open versus partial, this is a series basically comparing Gill's data versus Novek's data. And although the open series had a higher mean size of the tumor as well as a greater proportion of solitary kidneys, they found a lower rate of intraoperative complications and a lower rate of GU complications, mostly hemorrhage and urine leak. However, of note, a laparoscopic did have significantly reduced blood loss as well as length of stay in hospital. So in summary, laparoscopic partials, very technically challenging. It requires use of intracorporeal suturing. However, this technique is still evolving. At intermediate, oncological efficacy is similar to open partials. However, there's an increased rate of intraoperative and GU complications. So now to talk about ablation. Sure.
You compare Gill versus as though it's sort of a contemporary cruise, not randomized series, which is fine. But the other most important thing to consider is you're comparing Novak series, which probably accrued over 15 years prior to Gill series.
That's true. Yeah. That's very true. Yeah, it was during Gill's early experience with this laparoscopic technique, and Novak's been doing it for a multitude of years. So.
No, that's not my point. No, my point is the opposite.
Okay.
Gill's dealing with a more contemporary series of patients, more likely to be incidental illness discovered on ultrasound, as opposed to Novak's, which was a tertiary care referred.
True.
Very complicated set of tumors.
True. Yeah, there's a greater proportion of solitary kidneys and multifocality. Yeah, true.
Michael, in location, how many of these patients had tumors that went down in the highway? How are they involved in the location?
They define central tumors as those that were basically touching renal sinus fat or to the collecting system. It really depends on what series you're looking at, what they defined, what the proportion of central tumors were. So taking a look at ablation technology, indications are currently for patients with advanced age, limited life expectancy, high operative risk, and electively those tumors that are small and exophytic. The main options are cryoablation versus thermal ablation. And of the thermal ablation techniques, radiofrequency has been the most studied. So taking a look at cryoablation, it works by two mechanisms. The first is direct cytotoxic injury. Formation of intracellular ice crystals creates a hyperosmolar environment. This causes cell denaturation, shrinkage, enzyme denaturation, and cytoskeleton dysfunction. As well, it has an indirect ischemic injury with occlusion of local tissue microvasculature. It's performed with a rapid freeze, then a thaw, and these are called freeze-thaw cycles, and this maximizes the effect of this. The approach can be used, laparoscopic, open, or percutaneous. Advantage of cryo is that you can image the ice ball intraoperatively with ultrasound or CT or MRI. Probes between 2.4 and 4.8 millimeters can be used, and generally a double freeze-thaw cycle is used. Depressurization of liquid nitrogen or argon is used for the freeze cycle, and thawing is either passive or with helium gas. Temperature of minus 20 degrees Celsius is needed for a tissue or cell death. Again, you can monitor the ice ball on ultrasound, CT, or MRI. But the ice ball actually overrepresents the actual area of ablation. And you aim for an ice ball that's 1 centimeter greater than the tumor with a minimum margin of 3.1 millimeters. There's been demonstrated tumoricidal effects of cryoablation in the acute and chronic setting. And generally, cryoablations followed postoperatively with enhanced CT or MRI scanning. Generally, the lesions are non-enhancing, However, at 1 to 3 months, there may be transient rim enhancement, as shown here. Biopsies have shown no renal cell carcinomas to date, so it is thought that this rim enhancement may be from reactive changes. Generally, the lesions remain the same in size or decrease in size. So much like George Costanza in this episode of Seinfeld, exposure to cold can lead to shrinkage. And this series at the Cleveland Clinic demonstrated that, again, the average lesion size decreased over a span of 3 years, and 38% completely disappeared on MRI at 3 years. The longest follow-up series has been at Cleveland Clinic again. Their outcome of 56 patients with a minimum of 3-year follow-up. Mean tumor size was small at 2.3 centimeters. Their 3-year cancer-specific survival is 98%. 2 local recurrences. They initially had negative routine biopsies at 6 months. However, in further follow-up, they were found to have new enhancing lesions on MRI. This prompted biopsy and subsequent radical nephrectomy. The largest percutaneous series is in Mississippi with Bruce Shingleton. He's a urologist with a dual appointment to the radiology and urology departments. He uses an MRI guided with an open MRI machine intraoperatively. Patients are placed under GA and generally undergo 3 freeze thaw cycles. Of note, there's an anterior location at 20% of the lesions with no bowel injuries. In short follow-up at 9 months, there was no recurrences. There's been other techniques used as well, CT guided at Hopkins. They just recently published their literature about this. And 27 lesions, 16 lesions in follow-up at 6 months, 1 had enhancement. And that one case was a central large lesion. So they recommended cryo for small non-central lesions. As well, ultrasound guided is another technique. Morbidity from the technique is quite small. The risk of major complications or bleeding is less than 1%. The use of smaller probes may decrease the rate of bleeding. If bleeding is encountered intraoperatively, you can refreeze it or use flow seal, Surgicel, or argon beamer. Pain or paresthesia at the probe sites, the most common complication. And there's always a question of whether or not there would be injury to the collecting system. And this extracts from the initial prostate cryoablation series where there's high incidence of urethral sloughing. So at UCLA, they took a look at intentional cryoablation to the collecting system in a porcine model. They found that acutely and chronically that the collecting systems in these cryoablated lesions were actually well preserved. There's no GU fistulas, no clinical uranomas, and these findings were similar to that at Cleveland, where they saw urothelial regrowth at 1 month. As well, they tried instituting pelvic calyceal warming with a ureteral access sheath, and they showed there's no histological difference with using this. Of note, comparing that to RFA, we found that there's a greater acute change in the urothelium with RFA. Small numbers. So in summary, cryoablation can be reserved for small tumors less than 3 centimeters that are non-central. Advantage of cryo is that you can monitor the ice ball. There's really minimal morbidity from the procedure, and the early follow-up is promising. Yep.
I was just wondering if this technique is growing in usage. My understanding was not making that MRI, that double fold MRI anymore, so they can't follow it using that technique, or people just use ultrasound, CT now, and it's growing in that sense.
Yeah, the MRI is difficult because of resources and technique. I think more series percutaneously are being done, the CT guided, like at Hopkins. But I think the largest series are still done laparoscopically, MIS, compared to radiofrequency.
This study, did he show the degree of spread of tumors between, say, 1 centimeter and 3, small tumor size?
Sorry, for which study?
What was the size? Did he a range in size of tumors that you approach?
For cryo lesions? Yeah.
I mean, below 3 centimeters is one.
Yeah.
1.8.
Yeah, generally it's a small size. The larger lesions are usually in patients that aren't.
So his lower limit of attack is 2 centimeters? Because many of these are classified pathologically as adenomas.
True.
And so,
I mean, usually the lesions are usually greater than 1 centimeter before they consider treating them.
If you do autopsies in people over 50 years of age, 1 centimeter renal adenomas is almost ubiquitous.
Mm-hmm.
So a follow-up of a few months on trivial-sized tumors, this is an interesting technical experience, but I don't think it's really good.
Yeah, that's very true. I mean, that's the question is whether or not natural history of small renal tumors, comparing cryoablation, radiofrequency ablation, we have to really compare to a similar cohort or control group to see if there's any difference.
They're going to kill you.
Exactly.
And we put them through all of this. When the day is finished, what have you done?
Exactly. So taking a look at radiofrequency ablation, it uses high-frequency electrical current to produce excitation of ions and frictional heating. This causes denaturation of protein and as well as the membrane lipid bilayer. You need a tissue temperature of greater than 50 degrees Celsius. Again, it can be done open, laparoscopically, or percutaneously. The difference with cryo is that it's difficult to image the RFA effect during the treatment. You get a lot of bubbles on ultrasound when this is done. Generators are generally 200 watts, and proton temperatures of 105 to 110 degrees Celsius is achieved. In an effort to increase the size of the radio frequency ablated tissue, you try to reduce the amount of tissue impedance. And so you can do this in a variety of ways. You can inject a lesion with normal saline, and this is what they call wet RFA. You can use internally cooled tips. You can use multiple tined electrodes. As well, you can use temperature sensing and impedance monitoring to try to reduce the tissue impedance. First initial series of RFA, we're taking a look at whether or not RFA lesions produced histological necrosis. This is a study at Toronto where they ablated tumors and then immediately or at 1 week's time did a nephrectomy. It was interesting, they saw a viable tumor on H&E staining in 4 of the 5 in the acute group and 3 of the 6 in the delayed group. As well, in the delayed group, on CT scan imaging, 2 of the 3 that had of non-enhancing lesions, 2 of the 3 actually had tumor. There's some criticism of the study, though, in that they weren't using a high enough watt generator, and they didn't really know what tissue temperature they were achieving with their technique. Another ablation and resection study was at Leahy Clinic. They took a look at 20 tumors. They did open RFA followed by immediate partial nephrectomy. And on all 20, they found viable tumor interspersed within the RFA lesion. So while they performed an NADH study that takes a look at cell viability, and 4 of the 5 of these stains showed viable tumor. However, although these early studies showed viable tumor foci early on in the RFA, it was thought that the full effect of RFA may require more time. It's been shown in some animal studies that cellular changes continue 30 to 90 days post-RFA because of ischemic changes. As well, there's called into question of the accuracy of H&E staining as overt histological destruction may not be seen acutely. And so some investigators have suggested the use of NADH staining to really take a look at cell viability. However, there's been no long-term post-RFA histological studies in human series to date. RFA is followed by enhanced CT or MRI imaging. You generally see a low-density wedge-shaped lesion with minimal shrinkage in comparison to cryo. For exophytic lesions, you can see a fibrotic halo of fat. For endophytic lesions, you can see fat infiltration in 50%. Taking a look at the early data, again, a short follow-up with small numbers. However, their definition of success was non-enhancement of CT imaging, and it showed reasonable success there. Of note, the study by Gervais showed that only 5 of 11 had success in those tumors that were centrally located. More recent data, taking a look at the series at Southwestern by Jeffrey Kadedu and Matsumoto. They had different approaches, percutaneous, laparoscopic, with follow-up of approximately 1 year. Again, 97% were non-enhancing in their follow-up. Study at NIH, again with a 1 year follow-up, 96% non-enhancing. And probably the largest series of percutaneous RFA that's been published is from this group at Massachusetts General Hospital in Boston. They do a CT-guided percutaneous RFA. The mean size was 3.2 centimeters with a mean follow-up of 2.3 years, found 90% non-enhancing post-RFA. When they further stratify their data, taking a look at location, they found the best results in exophytic lesions, worse results in central and mixed lesions. Mixed lesions were those lesions that had components of the central and peripheral location. As well as stratifying for size, they found the best results in tumors less than 3 centimeters. And of note, multiple treatments were needed as the size got larger. As well, complications in RFA is similar to cryo. It's reasonably well tolerated with low morbidity. The most common complication, again, is pain or paresthesia at the probe site. There's less than 2% incidence of major complications. However, they do occur: bleeding, UPJ obstruction, and urine leak. There's been no reported bowel injuries. However, this could be a result of patient selection. There have been 7 bowel perforations reported in the liver RFA literature. Again, the question of whether or not it injures the collecting system. Taking a look at that UCLA study, they showed a high rate of urothelial damage acutely. However, at 30 days, the urothelium had repaired, and there's no clinical fistula uranomas. In that large series at Massachusetts General, they found a 2% injury, rate of ureteric injury. One was uranoma, the other was a ureteral stricture. So in summary, like cryo, RFA should be reserved for tumors less than 3 centimeters, non-central location, has minimal morbidity, and early follow-up is similar to cryo. However, multiple RFA treatments may be needed. So it's quite tempting to compare cryo versus RFA, but so there should be an understanding that both techniques are still in evolution. It's thought that cryo has decreased intraoperative pain, and the advantage of cryo is that you can monitor the ice ball intraoperatively. Investigators think that there may be a more consistent ablation effect from cryo compared to RFA, and there may be a question of less collecting system injury with cryo. However, RFA may be more hemostatic, it's lower cost, and there's a decreased probe site pain. And so where do we fit all these different techniques and therapies in our armamentarium of treating these renal masses? This is just a proposed algorithm, but we may see cryoablation and RFA being used more often in non-central small tumors. The role of laparoscopic and open partials may be reserved for more central lesions or larger lesions. And of course, the role of observation may play a bigger role, especially in those that are non-operative candidates. And so a lot of questions hopefully were answered today, but there's more questions that arise. Should we do an open partial nephrectomy or a laparoscopic radical in T1B tumors? Should I learn how to do laparoscopic partials, or will ablation be the way to go in the future? Should I do a fellowship in interventional radiology to do, cryo or percutaneous RFA? And the biggest question is, should we be even treating these small renal lesions, or should we just merely observe them? These are all good questions and perhaps topics for future grand rounds.